Okay, good afternoon from Manila, everyone, and good evening or good morning from the other parts of the world. Um, Thank you for joining us in the Secure Webinar Series. This is TA 6767, also known as a Security A. This is Secure Webinar number 10, which is the Pandemic Preparedness and Response, an increasing access to diagnostics today. I am Jeremy Gorospe, or GEM for short. I'm currently the health security expert consultant at ADB, and I will be your moderator for today. So we will be discussing about the importance of having increased access or access to laboratory and diagnostics, and the importance of having the results early on. Because as we see during the COVID-19 pandemic, the delays in the results of the diagnostics um, have cost us some precious time in trying to curb the pandemic. So I hope you all have a fruitful participation in our webinar, and I'll welcome Dr. Eduardo Banzon, the project officer and the principal health specialist of Asian Development Bank. He has also worked previously as the president and CEO of PhilHealth, a regional advisor of the World Health Organization, as well as a health specialist in World Bank. Doc Dodo?
Sorry, I always love it when Zoom says unmute yourself, right? We could have now. First of all, we would like to welcome first our experts, particularly our friends from MSF, who is of course will be providing us a lot with insights of the work that they've been doing on improving access to diagnostics. Also, our friends from the Philippine government, who's listening in, who will be reacting to the presentations, and finally, of course, experts that we have brought in who've been working in helping improve access to diagnostics to the Philippines and other countries in the region. As what Jem said, the SECURE, so that's a nice acronym that we have, is like a regional technical assistance platform that we've been using to support countries in Southeast Asia respond to the pandemic, including, of course, vaccination. And as we move forward with the post-pandemic, with the pandemic, and so I'm trying to stop myself from saying, with the post-pandemic environment that we're working on, we really want to make sure that the lessons that we had in responding to the pandemic will not be lost. And that's what Jem said, access to diagnostics was important. And as we also realize, of course, it's not just responding to the pandemic, but it's also crucial in universal health coverage. So we would like to listen to insights. We'd like to listen to findings of our experts in today's panel, in today's webinar, and try to listen and hopefully enlighten all of us on how we could explore actions, explore policies, do projects that can help countries, not just the Philippines, but countries in the region, not just in Southeast Asia, but both in the Asia Pacific, and where we could help countries expand access to diagnostics. So I will now leave the floor to Jem and the experts. I'll be listening in. This is a very interesting topic for everyone. Don't expect me to talk again. Because I would really love to hear everybody else who've been joining the meeting, try to give your comments either online or by asking questions later if there's time. So Jem, I leave the floor to you, and to again to all our speakers and reactors. Welcome again, and thanks very much for agreeing to do this webinar with us. Okay, bye-bye.
Thank you, Doc. For starter, we will give you the preview of the flow of the program today. So our first speaker would be Dr. Mary Ruth Rojas. She is the project medical referent at the Medicine Sans Frontiers in Tondo TB project, which will give us the perspective of increasing access in an endemic disease in the Philippines. Our next speaker is Mr. Svilen Konov. He is the International Contract Management Specialist for Medical Devices in ADB. Our next speaker would be Dr. Hani Kim, the Executive Director of the Right Foundation. And then we will have our reactors, Dr. Amado Tandok, the Division Chief in RITM, Laboratory and Research Division in RITM. And then Dr. Carol Rosales, Clinical Pathologist of the Office of Health Laboratory in Department of Health. And then we will open the floor for any questions from the audience. So with that, let me introduce to you our first speaker. Dr. Mary Ruth Rojas is a licensed medical doctor with a background in obstetrics and gynecology, but fell in love with humanitarian work back in 2009. She has worked for other international NGOs and is currently working at Medicine Sans Frontieres, Doctors Without Borders, since 2016. She has been involved in several MSF projects addressing different health-related issues on sexual and reproductive health, internally displaced people in a post-conflict area, non-communicable diseases, and was also the medical coordinator support assigned in the MSF Philippines Mission Office. In 2021, she started working as the Mobile Health Activities Manager for the Tondo TB project and is currently the project medical referent of the said project. Dr. Mary Ruth Rojas.
Hello, good afternoon, everyone. So I'll start to share my screen first. Kindly let me know if everyone is seeing the screen.
Yes, Doc, we can see your screen.
Thank you. So again, good afternoon, everyone. I am deeply honored to be in your presence to share our experience regarding with increasing access to TB diagnostics, supplementing laboratory capacity at the local level, and scaling up active case finding activity. Before I continue, may I have the honor of introducing our organization, MSF, or Medicine Sans Frontières, Doctors Without Borders. So MSF is an international independent medical humanitarian association which is governed by its principles of impartiality, neutrality, and independence. We give medical assistance to people affected by conflict, epidemics, people who are excluded from healthcare or disasters, and also neglected diseases. Currently, we are over in 80 countries in the world. We are also involved in doing clinical trials and operational research, which is supported by our epidemiological team, which is based in Paris, which is called the Epicent, which supports in doing study designs and also in abstract publications such as in the Union. In all of our activities, we ensure that we are always patient-centered. And also, we do collaborative advocacy to influence policy change. So I'm honored now to share with you the incredible journey of the MSF Tondo TB project in the Philippines. Our mission is to strengthen the diagnosis and treatment of tuberculosis in Tondo Districts 1 and 2, Manila, in accordance to the global plan to end TB by 2030, using the strategy of screening, diagnosis, treatment, linkage to care, and prevention. So our strategy revolves in screening, diagnosis, linkage to care, and prevention to ensure that the implementation of the complete TB cascade of care, we've utilized innovative approaches such as the use of a mobile X-ray, which increases the free accessibility of the screening modalities to the community. Coupled with this mobile X-ray is an artificial intelligence which has the capacity to give out real-time results, hence augmenting patient treatment and management. For the diagnosis, we have ensured the free accessibility to diagnostic testing via gene expert testing to the community as well, wherein to complete the whole cascade, we aim that all patients diagnosed are linked to care and prevention by ensuring that all of these patients receive free TB treatment via linkage to the nearest health center. Our activities started in 2022, wherein we have already managed to go to 8 different health centers of Tondo District 1, where we are targeting individuals aged 15 and above, with the target focus on household contacts as well, including household contacts aged 5 to 14 years old. And also, with the advent and the use of CAD for TB, or computer-aided diagnosis for TB, we have real-time chest X-ray reading and results as mentioned earlier, has greatly implemented the augmentation of patient management. In our ACF activities as well, we conduct an on-site sputum collection for all patients presumptive of TB, either symptom screening or chest X-ray through CAD. All of these specimens that are collected are transported by a trained motorcycle rider, and these specimens are delivered to the Rapid TB Diagnostic Laboratory, where MSF donated one 4-module and one 16-module gene expert machines. And now, with these two machines donated to the LGO laboratory to increase testing capacity, coupled with our own dedicated MSF laboratory technician, it has significantly decreased the turnaround time of the results to only 3 days to in the beginning of 6 days. With this, it has not only shown efficiency, it also greatly exemplared shortened duration of sputum testing to results generation and distribution. Also, with this, we are not also aiming in doing rapid screening and testing. We are also aiming to, as a part of the complete cascade of care, we are ensuring that contact tracing and contact investigation activities are conducted to all diagnosed patients. So all of our diagnosed patients in our ACF activity serves as the focal point, wherein our own dedicated team does house-to-house visits to ensure that these patients are encouraged to attend our own ACF activity that is near their residence. For the achievements, so from our activities since May 2022 up to December of 2023, a total of 200 ACF days was concluded, reaching 19,089 patients. From these, 845 were household contacts. And for the testing arm of the project, we are able to conduct 6,744 gene expert testing with a 4.7 positivity rate, wherein, as mentioned earlier, the turnaround time was from 6 days to only 3 days, plummeting the error rate of 2% to only 0.3%. Remarkably, 64 patients of the diagnosed patients were able to be initiated with treatment, and 83 patients accepted TB preventive treatment. Part of the key achievements of the project is the significant increase of the ACF participants from an average of 50 per day in 2022 to 111 participants per day in 2023. This is sparked by the highly motivated community residents because of the availability of the free access to the services. Because during promotion of these services, they are made known that there's a free X-ray activity and also a free testing activity if an individual is recommended to undergo such testing. And of course, the proximity of the activity in their residences, the quick results distribution, and the availability of an on-site patient evaluation. Also, with the implementation of the CAD for TB implementation, the current median turnaround time for screening is only 23 minutes per patient, compared to a 47-patient journey before the advent of CAD. And as mentioned earlier, the decreased turnaround time of sputum collection to release of results from 6 days in 2022 to 2 days in 2023. However, despite our successes, we also have challenges. First of which is a low uptake on expert repeat testing that has led us to propose the involvement of our own nurses in doing household sputum recollection. Second is the patient's refusal to treatment due to the possible socioeconomic concerns, which has prompted us to devise a plan or strategy in linking them to social welfare services and patient support groups. Then, there is the shortage of the DSTB drugs, wherein, with partners, we are planning and to forecast TB commodities that can supplement case-finding activities. Then, one of the last challenges is the link challenge with PPD and TST, where The first challenge is due to the presence of the multiple steps and the barriers to TPT initiation and completion. Secondly, there is the presence of the shortage of the PPD for TST. With these two intertwined challenges, the project aims to propose for these patients a simplified pathway without the need for TST for all household contacts under 15 years of age, given with shorter regimens and adapted formulations. Also, in addition to forecasting, an advocacy for an ordinance for population-specific TST exemption in Todo is well in plan. For the ways forward for this year, the project aims to continue doing the ACF activities in District 1 and District 2 of Tondo, with a total of 142 ACF days for this year, targeting at least 140 patients per ACF activity day, with a forecasted of 19,880 people screened. Also, to commence the household sputum recollection to be able to increase the uptake of repeat testing. Third, wherein we are touching on the sustainability and replicability, is the commencement and involvement of the barangay in the service delivery of the health center to the community. And lastly, is to increase the community engagement and support TB-related advocacies through a formation of a TB committee, which is led by the community. At the national level, we propose to replicate our success through first, sharing of the project outcomes, where 5 years worth of data and its analysis, our experience and recommendations can be of help in aiding in the improvement of the national TB program. Also, the sharing of the CAD study outcome, wherein we want to advocate the use of AI in TB screening in the community as part of the national guidelines. Thirdly, the advocacy on investing more on diagnostics, like gene expert machines, cartridges, or even in manpower such as dedicated laboratory technicians, for this to be able to decrease the turnaround time from sputum testing to the results distribution. And then, the advocacy on investing for additional installation and improvement of laboratory infrastructures. These advocacy would increase the testing capacity and also in line with the decreasing of the turnaround time of testing to results generation and distribution. To be able for the community to have ownership of the TB-related activities, we would advocate on investing in additional manpower and also trainings for the barangay health workers already situated in the barangays of the city. And lastly, sharing the experience and the approved ordinance in the creation of the TB committee for this to be able to have support in TB activities from both the national level, the national health system, as well as the local government units. In closing, I express my deepest gratitude for your attention and support. The success of the MSF Tondo TB project is a testament to the power of collaboration, innovation, and dedication to the health and well-being of communities. Together, let us continue to fight against tuberculosis. Thank you very much.
Thank you, Dr. Ruth, for that presentation on how the increased access in diagnostics on the local level helps us really achieve our the goals, and also the not just the availability, but I think one important lesson also in your presentation is that the awareness of people that the diagnostics are available is very important. So we'll move forward to our next presenter, Mr. Svilen Konov. Mr. Svilen Konov has a degree from the London School of Hygiene and Tropical Medicine. He has worked as a clinical trial methodologist on drug development, predominantly in the field of HIV and HCV, as well as concomitant diseases, with large pharmaceutical companies, and have developed research protocols and analysis plans. He has experience working with the EU regulator, the European Medicines Agency on drugs approval. In addition, Svilen worked with the World Health Organization on emergency medical services. He has been a long-standing member of the European AIDS Clinical Society, guidelines writing committee. Until recently, for close to 5 years, he used to manage the largest United Nations Development Program medical project that involved procurement of medicines and medical devices for about a budget of beyond $500 million US. And also the programmatic response to the health systems reform in Ukraine. Svilen is actually based in London. Svilen, you may have the floor.
Thank you very much, Jem, and I would like to thank you for this kind invitation to do this presentation. I will start with showing it, if you don't mind, right? Right. Okay, in this presentation, I would like to just mention some of the bottlenecks related to procurement of diagnostics in the region, and I will also try to provide some suggestions that certain settings may find useful in a situation they might be in at the moment. And I get
we can't see your presentation yet.
You can't see it, or?
Yeah, we cannot see.
Okay, if you give me a second. Right.
There, we can see it. Thank you.
Okie dokie. Sorry for that. I do apologize. Yes, I'll jump directly to the first slide. Just as a small reminder, the procurement cycle is divided into 3 main phases, and these are supply planning, purchasing activities, and contract performance, also known as contract management. Each of these phases have another 15 to 16 steps on its own. We're not going to go into that, but I'd like to draw your attention to some of the bottlenecks that have been noticed in the region on all these different phases, during those different phases. And having said that, we need to also take into account the fact that the region is extremely diverse in terms of certain disease spread, also the geography, political situation, etc., etc., etc. So we are very far away from the thought that one size fits all, but there are some generalities that perhaps you will recognize here. When it comes to the supply planning on this level, the first one that I would like to immediately mention as a bottleneck is the supply requirements. Quite often, they are either inaccurate or omitted. What is noticed in more pragmatic everyday terms is that very often when it comes to the amounts ordered, it is kind of that they're copy-pasted from the last year without any particular consideration of prevalence, incidence, geographical spread, and quite often people do not have any model, being it mathematical or just even on a day-to-day, so to say, model of quantification, namely the amounts of assays, test kits that they will need, as well as the strategic procurement of certain devices and apparatus, especially when it comes to the big ticket machinery, so to say. The second one is the complete budgeting and approval process. There are some procedural timeframes mismatch, namely when the budget is approved, when the budget is available, when exactly the actual high-level approval happens. So it may happen so that the process starts, say, in February this year, while the big ticket machine in particular is available only in September or October next year, exactly because of these procedural timeframes mismatches. The next one, the procurement requisitions and specifications, I will stop only, I will put a particular emphasis actually on the technical specifications. Why I do that? Because there is clear lack of expertise available, and this needs to be improved, needless to say. Quite often, again, talking about medical device, it is less so with assays and test kits, but it is more obvious with the medical devices. People simply take an available medical device, they copy-paste its specifications, and then they send it for approval. When I say people, I mean the procurement unit of the medical establishments. What happens in these situations? Sometimes well, being an approver in certain points of my life, I can just read the technical specifications of something, and I can tell you which company is the producer, how much it costs, which model the medical establishment wants. For obvious reasons, this is not the right way forward, and one can finish up with being linked to a particular company, and it's, if you excuse the expression, a certain toxic love. Love it or hate it, afterwards you need to buy only their cartridges, only their assays, and so on. And this may not necessarily be quite beneficial financially. The next one is the release funds to the procurement units. When it comes to the resupply in particular, we do not take into consideration, as if we do not, any stochastic models of disease development where there are suddenly quite sudden spikes in the incidence. We do not have any buffer that will allow us to keep on testing in these situations. When it comes to the bottlenecks in the phase of the purchasing activities, the access to procurement, we need to assess the procurement options to plan contract groupings, to plan the purchase. What we notice here is the lack of expertise in the procurement unit. We see, because of bureaucracy on many occasions, delayed approvals, uncertainty over dates and amounts of available funds. Also, when it comes to the preparing of bidding documents and the obtaining of of approvals, quite often there is a slow or float preparation of the documents. Certain sections of the application have not been even filled in, and non-standardized templates are used, and also the nomenclatures that are used in different countries of the region may differ even between different medical establishments. So for one and the same thing, product, good, different medical establishments may use different names, and PAPI or PAPI stands for pen and paper and ink procedure. 21st century, I'm not saying this in an offensive way, but it makes the work more problematic in a way that documents are being closed. Then when we see certain kind of sections that are not filled in, the approver needs to pick up the phone, start chasing the applicant or the medical establishment, the procurement unit, and so on and so forth. When it comes to the inviting of offers, problems with advertising, sometimes the advertisement for tender are made to somewhat of obscure means of communications we see, and not necessarily areas or actually media channels that will reach the largest or the widest possible suppliers or manufacturers, thus increasing the competition. There is quite often bidding documents revision, bidding deadline extensions simply to accommodate some supplier or producer. When it comes to the opening of the bids, because of certain policy or legal specificities, what comes as a problem or a bottleneck is that the final results of the evaluation, there are disagreements about those. There is also rejection by the monitor, who may decide that there are certain irregularities in the actual assessment. In the award contracts, we see protests by losing bidders, cancellations of tenders, as well as also irregularities in performance security. Last but not least, in this phase of purchasing activities, there is that we see certain late letters of request of credit, which delays the process, no down payments, delays on the side of the Ministry of Health, not necessarily, Ministry of Finance, not necessarily the Ministry of Health, and quite often funds are not available. When it comes to, sorry, there is a bit of a problem with, yeah. To contract management and performance, we see issues, and COVID showed that very, very, very well with raw material shortage. What happens is that suddenly there are huge orders on many sides, and usually this happens to large producer countries, like for instance China, when suddenly everybody wants one and the same thing. So no raw material shortage, overbooked manufacturing schedule, and usually the winners are the countries with larger financial resource, or buyers who have the flexibility of paying quickly, while countries with or establishments, regions with lesser resource suffer delays, and they do not sometimes even get the produce that they have ordered. Same goes with certain distributor issues, because they are subject of the same problems. The pre-shipment inspection and testing sometimes doesn't even happen. Certain goods are sent without being checked on the spot. And also there are issues with delivery to port of entry. To illustrate that, I will give you an example from my work in Ukraine. We were ordering again something from China. These were particular assays, if I remember correctly, and it was during COVID, it was during lockdown, there were no flights, so I had to ship them literally in the sea. When I say ship, I mean in the sea. They had to travel via the Red Sea, you know, it's problematic nowadays, and then again through the Mediterranean, and also into the Black Sea to get to Ukraine. Having said that, that delayed with weeks and weeks and weeks on end the process. So things like that can happen. And we are going back to the initial sort of common denominator. If the first and most important prerequisite of access to diagnostics and also to medical devices, of course, is their availability. There are many other reasons for lack of access, but unless we have them available, we simply cannot provide the access as such. Then another bottleneck is the clearance of goods through customs. Here, predominantly the problems are lacking of financial resource to pay the fees, irregularities of certain documents. I can give you another example. On one occasion, I was receiving tests from Turkey, and the company producer sent 4 tests more. In order to deal with the bureaucracy in one particular country, I had to spend 3 weeks of writing explanations, explaining why this has happened. The company had to support me with a letter. So these are also matters that need to be looked into. The post-shipment inspections, the issue there sometimes is predominantly, this has to do with medicines rather than medical devices and diagnostics, but still the data loggers may show higher temperature or lower temperature than the one that is necessary to keep the devices and the diagnostics in a working mode. And last but not least is the problems that can be encountered with the insurance and maintenance. What do I mean by that? Again, in the technical specifications, sometimes no insurance or maintenance clauses have been foreseen, envisaged. As a result of that, just imagine a situation if you are in a medical establishment where you do, for instance, 30 imaging images per day. Suddenly you call the company producer, you ask them for help because the machine broke down. You finish up with a situation where they tell you, oh, today is a Saturday, you will have to wait until Tuesday because only then we can fly a specialist to you if you don't have the spare parts, for instance, or an engineer in-house. And then 3, 4, 5 days times 30, you already are with a backlog of 150 patients who are waiting for an image. And then you start receiving phone calls from the clinicians. Hello, this is an emergency. Can you please deal with that situation while I'm waiting for 3 days, etc., etc. Right, some of the curative suggestions that I have here. Number one will be to really assess anew and to revisit the national procurement policies. We keep on talking about that, how COVID taught us a lot, how we saw many and different problems, we have lessons learned, but as if we do not act on them. And it is very disappointing to see that, especially here in Europe, in particular in the European Union, as if we became blasé. And again, we saw what the flows are in our system when it comes to procurement. We just need to start doing something about it rather than just talk about it. And it's a fantastic initiative on ADB to do that. Another suggestion that I have, it may not work necessarily everywhere, but it can be a good way forward, is to open the market to international competition, not to keep it only locally or nationally, thus reducing the limitations of using in-country supply only, and possibly reducing the expenses that a third man or middleman brings into this equation. Next thing is to create an electronic procurement information system to standardize the forms, also to streamline the process. I'm sure that the people who approve among you will understand me completely. It will be a paradise to see a fully filled form with all the information in it. It will be absolutely fantastic. And in an electronic form, you can do that. You can simply do it in a way that if there is a missing field, then the application cannot be sent. Done. Then the next one is to create a system of e-government procurement so that everything is transparent, and there is a lot to be said about transparency in the region. Again, I'm not trying to be offensive, but we need to talk about it. And also this will enhance the tender coverage. The producers and also the suppliers will be able to immediately find information about tenders and so on. And also to invest in the quality of data collection, and when possible, use certain mathematical modeling or verified system of adequate quantification of the goods, what we need, in what amount, when, is it kind of a temporal, is it seasonal, and so on. And my last slide is also to look into multi-year framework or long-term agreements where the legislation allows it again, so that we can benefit from a more secure supply. Again, this has pluses and minuses, but there are long-term agreements where you are not obliged to procure on a regular basis, but only when you need it. Still, this can help a lot if there are certain immense fluctuations in the price of the testing kits as well as the assays. Also, to look into pooled procurement on a regular national and international level, where different organizations or regions can exchange tests and kits, as well as use their own machinery for patients from other regions or even other countries. It has been done on many and different settings, so it's not something of a science fiction so impossible. Also, to enhance the procurement technical expertise, the individual skills and knowledge, the organizational and national policies. Also, to create appropriate standard operating procedures, because what I notice, say in the Philippines, for instance, certain Medical establishments have one SOP, others have another. They don't necessarily match, and it's difficult to kind of follow the process where, how, and what. The nomenclature on national level, price lists, also the expertise on market research. How do we really find what we need from where, how, for what price, and technical specifications. Again, I return to that. Last but not least, particular emphasis on insurance, the maintenance conditions, available of spare parts for what year during the life cycle of the machinery, and also the in-house availability of engineering expertise. Here I will stop, even though there are many other topics that I would like to quickly mention, like procurement of innovative products, procedures for fast registration in the country, participation of civil society, and so on. But here is my email. If you have any interest in more nitty-gritty details, please feel free to write to me. I will gladly take a look into a particular case or whatever you may decide. Thanks again for the invitation, and Jim, back to you.
Yeah, thank you, Vilen, for that very detailed with examples of the bottlenecks that we experience and how we can possibly cure them, as you noted. So our next speaker is Dr. Hani Kim. Dr. Hani will speak about how public-private partnership can contribute to improving public access to diagnostics. So Dr. Hani Kim is the Executive Director of the Research Investment in Global Health Technology, or also known as the Wright Foundation. Dr. Hani Kim completed her PhD in laboratory medicine and pathology at the University of Toronto in Canada, her postdoctoral training in molecular immunology at the Max Planck Institute of Immunology, Germany, and her MPH at the Johns Hopkins School of Public Health in the US. Prior to joining the Wright Foundation, Hani worked as a program officer at the Bill and Gates Foundation and as a research associate at the Johns Hopkins School of Public Health. Dr. Hani also conducts and publishes independent research on the political origins of health inequity. Her recent articles include We Need People's WHO to Solve Vaccine Inequity, and We Need It Now, the socio-political context of the COVID-19 response in South Korea, and the critical assessment of the ideological underpinnings of current practice in global health and their historical origins. Dr. Hani, floor is yours.
Thank you, Jen, for your kind introduction. I would like to thank the Asian Development Bank for inviting the Wright Foundation for the opportunity to participate in this very important discussion. So today I'm going to share my screen now. I would like to spend about 20 minutes to, let me maximize screen, on mainly 2 points. I would like to describe to you the problem that we've, I think, all gathered here to try and solve, and that relates to the global diagnostic gap. So I would like to spend the first 10 minutes or so to describe what we mean by the diagnostic gaps that we see globally. And then I would like to switch over to what it is that the Wright Foundation is striving to achieve in order to contribute in some meaningful way to closing the global diagnostic gap. So in the next couple of slides, I would like to step back and share with you what we mean by the diagnostic gap, which relates to the problem that we are trying to solve. So shown on this slide are the data indicating the COVID-19 testing rates per every 1,000 individuals observed across different countries, categorized according to their income group as defined by the World Bank. So if you look at the left-hand side, as noted in 2020, most high-income countries have satisfied or exceeded the dotted line, which represents the WHO target level for weekly testing for every 1,000 individuals. Now, as you go down along the y-axis, as you reach the low-income countries, most of those countries fail to reach the WHO target. Now, the good news is within a span of 1 year during COVID, we have seen an improvement. So you see all the countries shifting slightly to the right demonstrating a greater weekly test rates across the countries. However, you still note the huge disparity across countries, because if you look at the low-income countries indicated at the very bottom group of countries, still a significant number of those countries cannot meet the WHO target testing rate. So this points to a gross inequity in access to diagnostics. Now that's an inequity of diagnostics if we look at the country level. What about if we look across different health conditions? So there was a seminal paper that was published by the Lancet Commission a couple of years ago that examined the diagnostic gap across what is called the 6 tracer health conditions. The tracer health conditions are the health conditions for which there are clear diagnostic criteria and preventions or treatments exist. And if you look at the group of 6 health conditions presented here, the red arrow corresponds to the diagnostic gap. So for example, for malaria, for every 100 patients, only 38 of them are successfully diagnosed, which means the remaining 62% remain undiagnosed. Similarly, for diabetes on the left-hand side of the x-axis, only 44% get diagnosed. And as you can imagine, what you can't detect, you can't treat. In other words, diagnostic gap represents the major bottleneck in the cascade of care across multiple health conditions. Now, there are many factors that contribute to inequity in access to diagnostics. I would like to illustrate one of those contributing factors on this slide. There's a huge inequity in both the economic resources as well as the level of technical know-how to develop and manufacture essential diagnostics globally. So if you look at the left-hand side of the pie charts, only top 4 manufacturers are responsible for roughly 50% of the global supply of in vitro diagnostics. Now, if you look at the medical imaging, it gets even more pronounced that the top 4 companies or top 4 manufacturers, mainly in North America and Europe and one in Japan, they now make up for 75% of the global supply of the essential medical imaging. In other words, there's a huge need to strengthen the capabilities. I would call that the means of innovation, the means to research and develop and manufacture essential diagnostics globally, so that we do not see this inequity in their ability to manufacture the essential diagnostic tests. So if we speak of research and development needs, what are the areas that need to be prioritized? And there was an excellent review paper that was published by Dr. Ilesh Jani from Mozambique that highlighted at every level particular areas that need to be improved in terms of research and development for diagnostics. So at the central lab or the tertiary lab setting, as you know, the nucleic acid tests usually are concentrated at the level of central labs, and they have the advantage of being highly specific and sensitive, and they're able to process a high throughput assay. However, they're often too expensive, therefore they limit access. So we really need to bring down the cost while not compromising the sensitivity or specificity. And we do need a method to allow rapid sample transport and a method to deliver the electronic results to really close the gap between diagnosis and care. Now, if you go down to the bottom row of the table, rapid immunologic tests have been hugely impactful in improving public health because they offer lower costs and therefore much easier to deploy in most settings, especially in community settings, not necessarily at the central lab settings. At the same time, there's still a huge room for improvement in terms of their sensitivity and specificity. Now, the third category is an area that most funders, including Wright Foundation, is paying particular attention to, and that is the need for either true point of care or near point of care nucleic acid tests. So if we could use our imagination to really draw upon the advantages of what we have from the PCR-based platform and the advantages of the rapid immunologic tests. So something that is highly sensitive and specific, but also can allow lower cost of production and the ease of operation. So something that can combine the benefits of the both worlds, the PCR system and the rapid immunologic test, would be highly desirable. And I ask you to keep this point in mind as I now come back to some funding areas that the Right Foundation is very keen to support, because we do want to directly respond to some of these gaps that have been identified in the field. So I'd like to introduce to you briefly what we stand for and what we try to achieve. So Right Foundation represents Korea's first nonprofit organization with the singular purpose of funding global health R&D. We were established not so long ago, back in 2018, to engage more Korean life science partners in the efforts to develop and make available critical health technologies such as vaccines, therapeutics, biologics, and diagnostics, not just as any commodities to be bought and sold on the market, but as public goods. We represent the public-private partnership with the Korean Ministry of Health and Welfare as the biggest donor, followed by the Bill and Melinda Gates Foundation, as well as a group of Korean life science industry partners. Because the source of our funding from the Korean government is the official development assistance, our ultimate success really depends on our ability to meaningfully contribute to global public health and global health equity. And that is in a way described on this single slide, showing our mission and strategic goals. Our mission is simple. We hope to contribute to alleviating the burden of infectious diseases that disproportionately affect the people in the World Bank-defined low and middle-income countries. In order to achieve that mission, we pursue 4 strategic goals. First is product development. Again, as I've just mentioned on the previous slide, we strive to support efforts to develop essential health technologies as global public good. Second, we do aim to serve as a platform to catalyze meaningful international partnerships so that these partners can co-create and develop the essential health technologies. The third and the fourth area also represent the areas of our funding. Evidence generation we deeply care about because we believe that it is essential to learn directly from our partners in the low and middle income countries about the gaps and needs that should be filled by our product development efforts. So we do have a separate award category specifically for this aim. Last but not least, our brand new award category, Training Award, is intended to support training of LMIC personnel in manufacturing essential health technologies with the initial focus at the moment on vaccine manufacturing. This is just another slide to rephrase our approach to achieve our strategic goals. Because we are a Korean organization utilizing Korean government's ODA money, we hope to leverage and contribute Korea's R&D capabilities to ultimately to improving equitable access to essential health technologies. In so doing, we aim to support not just R&D, but technology transfer all the way up to licensure and WHO pre-qualification with a clear path to regional and global public procurement so that our funded products get distributed within the local public health system so that it can reach those who are in need of the essential technologies, regardless of their ability to pay. So just the bottom half of the slide to summarize what value we try to bring to our grantees and our partners. First and foremost, as a funder, we fund the activities that I've just described. But in addition, we hope to provide insights on identifying the gaps and needs in global health R&D, such that the R&D efforts do successfully reach the public and global public procurement, the regional or the global public procurement, and they reach the people who are in need. We also actively engage the key stakeholders for impact. We catalyze partnerships, and we advocate to various regional and global stakeholders, including the Asian Development Bank, to leverage Korea's strengths in the regional and global R&D ecosystem. So when we speak of Korea's capabilities in R&D, exactly what is it that we try to leverage and contribute to global public health? So here is a slide that focuses on the diagnostic aspect of Korea's strengths in R&D. And some of you may be aware that during COVID, Korean industry partners have contributed tremendously to meeting the needs of the COVID-19 testing kits globally. So Korean Ministry of Food and Drug Safety, which is our national regulatory authority, has approved close to 500 COVID-19 in vitro diagnostic kits between 2020 and 2023 alone. Now, this is hugely encouraging, and from the right foundation's perspective, now we want to focus our efforts to really channel these strengths towards not just exporting to various countries, but to access the public procurement so that, again, these funded products are accessed in an equitable manner. So since our establishment in 2018, diagnostics represent the second largest area of investment after vaccines, whether you look at in terms of the number of grants we funded or the amount of investment we have made. So out of 58 total grants, 16 grants represent diagnostic development grants. And of the 79 billion Korean won we have invested over the years, approximately 18 billion Korean won correspond to the investments we've made in diagnostic space. This is a busy slide, so I don't want to go through all the details, but suffice to say that under the Product Development Award for diagnostics, we fund all the way from something that is near or at the initiation of clinical development or validation of the prototype that was developed, all the way to licensure and or WHO pre-qualification step. And we do fund tech transfer. In terms of disease, we focus on infectious diseases that show disproportionate burden of disease or deaths in low and middle income countries. I invite you to visit our website to really see the funding scope for diagnostic projects. How do we aim to achieve global and equitable access? We are very privileged to be working with a group of grantees and partners that are committed to our global access policy, which essentially commits our grantees to supply, pricing, and license. The supply term indicates our grantees' commitment to ensure the sufficient supply of the funded products occur to low and middle income countries at a price, this leads to the second point, that is affordable for the governments in low and middle income countries to procure, to distribute within their public health system. And for whatever strategic reason, if our grantees choose not to supply, we have their commitment to license it out so that those who are in need of that funded product do have access to them. The bottom line is Right Foundation isn't interested in owning the IP, but we do ask our grantees of the commitment to make sure that the funded technologies reach those who are in need in an equitable manner. The last two slides, I would like to just give you a glimpse of what we are hoping for in terms of impact. So our 5 most advanced grantees in the diagnostic space are aiming for public procurement for equitable access, targeting malaria, tuberculosis, and pneumonia. And I am excited to share with you all that our first example of success comes from efforts by SD Biosensor in collaboration with PATH to develop and make available second-generation G6PD test. So for those of you who are not so familiar with G6PD deficiency is the most common human enzyme defect that affects red blood cells. And it happens to be highly prevalent in areas that show malaria, which is another disease that infects red blood cells. And G6PD deficient individuals risk having severe adverse reactions if they're exposed to a very widely used class of malaria drugs. Therefore, for governments who aim to control malaria, it's extremely important to have a way to identify those individuals who are deficient in G6PD so that the government can guide clinical management of the malaria cases. So SD Biosensor has so far successfully achieved not only a stringent regulatory authority approval from the Australian government, they've also obtained a regulatory approval from the Brazilian government, which resulted in a successful policy recommendation to adopt a single-dose tafenoquine and standard G6PD test for the treatment of relapsing P. vivax, Plasmodium vivax malaria. So we are very proud to be a funder of this important work. And although we are humble in knowing that there's still quite a way to go before ensuring that this product reaches those who are in need globally, but we are grateful that SD Biosensor and PATH are committed to achieving that goal that is shared with the Right Foundation. So with that, I would like to thank our funders, the Korean Ministry of Health and Welfare, the Bill and Melinda Gates Foundation, as well as the 7 Korean life science companies. And I thank you all for your attention. And I invite you to visit our website for funding opportunities that are open right now. We will be very keen to receive applications from you all. Thank you.
Thank you, Dr. Hanky, for that presentation on letting us know the mission and what actually the Right Foundation do, and how the PPP can help close the gap in inequality in low and middle income countries. Yeah. So the next part of our webinar, we will proceed with the open forum. And our first reactor would be Dr. Amado Tandok. Dr. Amado Tandok III is an anatomic and clinical pathologist trained at the University of the Philippines, Philippine General Hospital, and a board of governor of the Philippine Society of Pathologists. He is also the division chief of the Laboratory Research Division of the Research Institute for Tropical Medicine, where he leads 10 laboratory departments designated with 18 national reference laboratories for infectious diseases of the Department of Health. These national reference laboratories provide confirmatory testing, outbreak and surveillance testing, laboratory quality assurance, technical assistance, training of laboratory personnel, and product evaluation services. He likewise led the Institute's laboratory response to COVID-19, assisting DOH in setting up the COVID-19 molecular laboratory network nationwide, establishing a national quality assurance program for the laboratory network, as well as evaluating in vitro diagnostics, medical devices for SARS-CoV-2 detection in collaboration with the Food and Drug Administration of the Philippines. Dr. Tandok?
Yeah, thank you. Good morning, good afternoon, and good evening. And thank you for providing RITM with this opportunity to react to the 3 very relevant presentations from Dr. Rojas, Svelen, and Dr. Kim. So with the Philippines having one of the highest burdens of TB in the world, we at RITM can certainly relate with the work of Dr. Ruth. Even if we have more than 3,700 TB labs throughout the country already, from the national to rural health unit level, the diagnosis and linkage to treatment of TB still needs to be strengthened. There are indeed various coexisting and competing health priorities. My key takeaway from the first presentation is the importance of the local context in designing innovative solutions to address public health problems. There is no single solution that will work in all settings all the time. And we applaud efforts of trying out new technologies in fighting a disease, but a primary consideration on how these technologies can be assimilated locally. An important note is that even with the provision of funding, equipment, introduction of new technologies, advocacy, the testing capacity will always be a function of the adequacy and availability of skilled human resources. We have to consider that staff at the lowest level, at the barangay, they have a daunting task of implementing government programs on the ground. The recommendations made by Dr. Ruth are practical and should be provided to the National TB Control Program. We at the Institute, including the National Reference Lab for Tuberculosis, we remain very hopeful, along with the development partners, that the pilot project experience will indeed be replicable, scalable, sustainable, and can be applicable to prevention and control of other diseases. Laboratory testing should be accessible, definitely, low cost, rapidly deployable, standardized, and quality assured. The demand for testing increases manifold in the face of large surges of cases and samples. So we can also resonate with the testing gap mentioned by Dr. Kim. As the COVID-19 unfolded, Philippines started, if you can imagine, with just one testing lab, which is our institute. And we made a quick inventory of molecular testing capacity, and we noted that there were very few labs throughout the Philippines. Some of them are even in the academe that had the potential to do PCR. So over the next months, we led teams around the country, assessing and setting up PCR labs, training the staff, and assisting DOH in the provision of the equipment, reagents, and supplies, and eventually up to us to come up with a quality assurance program for these labs. So at its height, the lab network had more than 350 active labs, representing a potential to support outbreaks and surveillance testing beyond the virus at this time. So one important thing that should be strengthened in the country definitely is R&D and manufacturing of IVD. There is only one local Filipino biotech company which came out with a diagnostic test for SARS-CoV. Suffice to say that RITM was saddled with the task of the first response, lab expansion, and quality assurance. But we are keen on improving our R&D capacity in collaboration with international and local partners. Finally, I could distinctly remember scrambling for supplies at first within the Institute's other lab departments. We had inquiries and requests for quotation being rejected by manufacturers themselves due to the shortages internationally. We were only able to survive at the outset from PCR kits donated by other countries until the government was able to procure its own following a passage of an emergency legislation. And it was still a challenging procurement process. So despite the availability of funds, there were no local suppliers, and the country had to resort to international procurement efforts. Transport, shipment, mobility, as shared earlier, were severely hampered and affected deliveries and distribution. So steps should definitely be taken to learn from the experience moving forward. One thing is that whether it's in an emergency or even in peacetime, procurement will always be challenging, especially if the problem is not analyzed. So what was presented was a systematic approach to laying down the process, identifying the bottlenecks which can guide us in employing strategies to address them. But out of all the very interesting points made by Svilen, I think revisiting the national procurement policy should be a first significant step, and seriously pursuing e-procurement after there is full clarity of the local procurement to payment process. That's it. Over to you. Thank you.
Thank you, Dr. Amado Tandok, for that one. So our next reactor is Dr. Carol Seidel Evrosales. Carol Seidel is an anatomic and clinical pathologist. She is currently a consultant pathologist at the Office of Health Laboratories at the Department of Health. a visiting consultant pathologist at Quirino Memorial Medical Center, and a part-time assistant professor at Francis Cabrini Medical Center, College of Medicine, Department of Pathology. Dr. Rosales completed her pathology residency training at Quirino Memorial Medical Center and her Doctor of Medicine degree at the De La Salle Health Science Institute. Dr. Caro?
Hello, good afternoon, everyone. Hello.
We can hear you, Doc.
Okay. So first, I would like to thank ADB for inviting the Office for Health Laboratories in this activity. So on behalf of the entire OHL team and our director, we're very thankful for this opportunity. So actually, Dr. Tandok was able to point out a lot of things already, a lot of important things already. Just to add on the presentations, for the first presenter, I would like to first congratulate them for this study that they had in Tondo. So hopefully, they would be able to share this study um with the the entire community that they have in Tondo. So hopefully this could provide a positive impact to their community from the barangay level to the local government, and then also for the national level. Hopefully this study can be used by the national level, especially for the DPCB who handles the TB program. So this is an important study wherein they could be able to use the data for this, especially with their current initiatives towards the optimization of certain programs that they do have for TB. And then for the second presentation, so for the bottlenecks with regards to procurement, um, actually this is a very good study which I think would be very useful and is very vital and is very relevant to the current condition of our procurement system in the country. Um, as mentioned earlier, the procurement system in our country is very challenging. We all know how the process is very slow most of the time. It's very lengthy. It's very tedious also. So hopefully, again, this study can be used at the national level also to be able to lobby for changes in the current procurement law that we do have. And then for the third presenter, um, this is a very timely presentation because currently there has been a framework developed for the public-private partnership with the Department of Health. So I think this is something that is very that is worth exploring and something that the Department of Health would really like to get to engage in right now, especially in terms of the diagnostic services and the diagnostic equipments that can be available for use by our public health laboratories. So um, this study presented can also be of great impact when it comes to if presented at with our with the agencies in the Department of Health, can really affect the economies of scale. And actually in the Office for Health Laboratories, those those agencies that were mentioned, um, um, hopefully we can be able to work with them in the future in the activities that we are planning to prepare also, with regards to the Philippine Health Laboratory System that the Department of Health is trying to establish. This is something that we are really trying to explore right now. So hopefully, in terms of the innovations that we are trying to put up, we could be able to form a good collaborative relationship with these agencies. So to all the presenters, thank you with your presentation. So uh, everything was really engaging. So thank you.
Thank you very much, Dr. Carol. Now, I would like to request all the speakers and all the reactors to please turn on their camera. Yes. So there's a question I think this is for Dr. Ruth and perhaps for Dr. Hani as well, Hani Kim. So the question was, I was curious to know if under National TB Program or General Health Diagnostic Strategy, is sequencing also something countries are considering and something that Right Foundation and ADB would support? Maybe Dr. Ruth first? Sorry, Dr. Hani, please.
Okay. So we could consider funding genomic surveillance efforts as part of our evidence generation. So as long as it does satisfy our criteria of investments, which include that it has to be intended to improve ability to prevent or control infectious diseases that disproportionately affect the low and middle income countries. Let me try and think whether there are other criteria for evidence generation. I think that might be it. So yes, it is within our scope as long as it satisfies the disease focus and if the applicant can clearly demonstrate that it corresponds to an unmet needs.
Thank you, Dr. Hani. Dr. Ruth?
Hello. So unfortunately, the technology is not yet readily available in the country, but there are ways forwards on how its feasibility can be done in the country. It's already present, but it's not yet being available for use.
Okay. Perhaps I could ask Dr. Tandok or maybe Dr. Carol if the general health diagnostic strategy, the sequencing, is it something that the country is considering before I proceed with Doc Dodo on the possible support from ADB?
Yeah, we're already in the process of setting up sequencing for TB. And we've started with a lot of work on sequencing in COVID and other pathogens. But definitely it's part of the work that we are doing. Currently, it's not part of the program.
Okay. Dr. Carol, is sequencing part of the program or in the plans of Office of Health Laboratory?
So currently the TB program is under another bureau, so under the DPCB. However, we are also trying to integrate right now since we are also being asked regarding the TB program and the HIV program. So right now we're also trying to integrate the plans of DPCB with regards to the TB program and the HIV program. So right now, that's all I can say.
Thank you. Doc Dodo, can I call you back in? There's a couple of questions regarding ADB support.
Okay. Uh, Thanks, Jam. Sorry.
So first question, Doc, is general diagnostics something ADB can support? We've already provided some answers to that. However, there's a follow-up question, as well as support that ADB can provide to countries.
I think I'll probably step back a bit. I think this is probably listening to the panel and the reactors, because I think what's crucial is what do we consider as essential diagnostics. Okay, so for the it's like essential medicines, right? So in a sense, when the bank comes in, when we talk to countries, and by the way, we don't usually do and provide financing or provide technical advice. And financing is usually premised that the country will eventually mobilize its own money. So we're talk loans more than grants. We usually try to say, okay, is this really something which the country which the country needs? And then that's where we bring in the experts and basically they start telling us, okay, those are the essential medicines. And so let's say vaccines, then that's something ADB will come in and talk with the country or say, we will help you. If you need financing, you need money upfront now. So you, for example, get the vaccines now, then we could provide you with a loan. All right. If a country is considered to be considered to be eligible for what we need to be called concessional loans or even grants, then that will be the financing that will come. Philippines, of course, is not eligible for that, so it's going to be loans, and a lot of other countries, Asia Pacific. Then, so if we start talking about equipment, that will be the same story, right? So we start talking about diagnostic equipment. So the question is this something that the country would actually consider to be essential, necessary? And if they do, then we could provide the financing, then we could provide mechanisms, we could provide the study, help look into the studies, like what surveillance doing, so to make sure that these diagnostics can be procured and installed rapidly. If genomic, and this is where I now go to genomic sequencing, because we all know right now, whoever we talk to now, it's not just TB. Everybody's talking about genomic sequencing. Everybody talks about the Philippines is actually talking about the Philippine Human Genome Project, and you go from one country to the other. It's basically look into that. It's being talked about. It's being you talk to NCD's people. They also talk about genomic precision medicine. You talk with other programs, and so I think that's a question that probably the expert needs to resolve for us. Is it really something that's a must now? Is this something? Have we reached a point that genomic sequencing is something that countries should have, that developing countries should have? And as I said, it should not just be focused in one in TB. And if that's in a sense that's going to be the sort of the consensus, then is this something that ministries of health, Department of Health are actually wants countries to start bringing in, investing in? And once that reaches that point, so we in ADB could obviously come in and provide the financings. It's dependent, of course, on the status of the country as we engage with them. If there's need for analytical work for these answers to the answers to the question I've raised, so the answers can be given, we can go into that. But I think there may be other bodies like other institutions that may be better positioned to do that, or you can work with and get those answers. And so I think that's how we respond to the anonymous attendee. It's not something like, hey, here's something great, please fund this. This is not the way it should be done. It should be has the Department of Health, has the Ministry of Health, has their consensus that this is something that needs to be invested on by a country. So I think I'll stop there.
Thank you, Doc. I would like to open the floor for the participants if there are further questions. Yes, Dr. Hani.
Thank you, Jen. I was just curious whether Asian Development Bank any interests in playing a leading role in the Asian region to organize some sort of a pooled procurement mechanism for diagnostics. Because I believe that ADB is extremely well positioned to play such a leading role.
Sorry, Dr. Honey. Sorry, I'm just gonna open my. I've been trying to close my video, so you won't ask those kind of questions. I think the answer is yes, right? But rather than talk about food procurement, I think it's improving access. I think that's what we're having this webinar, improving access to the diagnostics. Now, how that's going to be done, I think that's going to be part of our challenge, right? The idea, getting countries, let's say, to agree to buy together is very difficult. It never happened during the pandemic. We had a lot of discussions with countries in the pandemic so that they actually say, okay, can 3 countries work together so we could just procure the vaccines together? It never happened. It was always a country-specific decision. But there is, of course, always value, in food procurement. Maybe other mechanisms may be better, right? So the way the Gavi and the Global Fund did it, right? They got money from everybody and they get donors and they basically buy. It's a kind of pooling as well. But countries mobilizing their own money, their own procurement, their own budget money, and saying we'll buy together, that's going to be that's something we all wish can happen, but may not be present right now. But there are other elements of pooling, if we want to use the word pooling, that we could work on. Having, for example, helping, for example, provide guidance on what should be the equipment that should be bought. Making price transparent, these are the kind of things that we could explore, and this work that we can that we're very much interested in doing.
Yeah, thank you for the response. I mean, you're right. It is ultimately an access issue, not the procurement itself. I guess we won't have time to solve that today on this call, but I think ultimately what the region can greatly benefit from is some ways to predict demand and accurately demand, and that allows planning for production and possibly even stockpiling some of the essential diagnostics. So in order to do that, some sort of a pooled mechanism would be useful, is what I was thinking. But I understand your response. There are realistic constraints in orchestrating that.
Yeah, sorry, but I think this is something we should all start. I always see webinars as something that can trigger this kind of collaboration, because that's we have a nice mix of people here. So let's continue, as I said, the discussion. Diagnostics, unfortunately, is something people don't talk about. Everybody's an expert in access to medicines. Everybody is an expert on insurance, in health insurance. You throw a stone in Asia, there's an expert somewhere. Everybody can, but diagnostics, there are very few expertise that we have right now, and we're so dependent on suppliers. Your slide is so powerful, right? The monopoly of the suppliers is unbelievable. The pandemic actually changed a lot of that. We never thought, for example, that the COVID-19 test, you have so many suppliers that came out because the demand was so huge. And similarly, we saw that happening in not just diagnostic equipment, but also, for example, in how do we call it? Ventilators and all, the whole market. So probably a demand work assessment, something we could jointly work on. So I need to step out. I think I would probably, I don't know, I'm publicly saying here, this is probably, we can explore that for Southeast Asia. So we'll look forward for us to bothering you, bothering MSF. And we'll have a chat on how we could start some work to do a rapid assessment on the demand for diagnostics. And plus, the big part, we also have to resolve what we will study, because diagnostic, unfortunately, is just so broad. It's like all over. So we also need to hopefully, I think there might be not a diagnostics expert already, sort of a taxonomy of diagnostics, but we'd gladly see if we could have a much more Asia responsive, Asian context, the taxonomy of diagnostics. And once that is out, then I think it will simplify our work. So probably here in this case, probably the right foundation, you guys should lead that. Unless of course, if our friends from WHO would also do that. I'm looking at Dr. Tando. Hopefully they also do that. Fortunately, they haven't done that taxonomy, but I think lots of work for us to do. But so again, I would like to thank everyone. Velen, I think I'm not seeing you on the screen, and everyone. So, but looking forward to further discussions. Jem, I have to leave the floor. I'm sorry. There's always something else for me. Okay, bye bye.
Thank you, everyone. Unfortunately, we're running out of time. There are very interesting comments and point of views at the chat, but and I would like also to thank the experts and the reactors for this webinar. As we can see, we have seen how the importance of local context in innovation and driving results is important, as well as the bottlenecks and in the procurement process can be addressed by increasing capacity. And evidently for me, what stands out is providing electronic systems such as the electronic procurement system, and how organizations such as the Right Foundation can help provide public-private partnership, which in effect close the gap or provide access and availability of diagnostics and close the gap in inequality. So with that, thank you very much, everyone. And again, thank you to our experts and our reactors for this, for giving us your time to share your knowledge in this webinar.